Welcome, everybody. Let me begin by land acknowledgement. We wish to acknowledge this land on which the Fields Institute operates. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, this meeting place is still the home to many Indigenous people from across Turtle Island, and we are grateful to have the opportunity to work on this land. Greetings, good morning, good afternoon, good evening, wherever you are joining us today. A very warm welcome to the Fields Institute and to this special symposium. My name is Kumar Murthy. I'm the director of the Institute, and it's one of my privileges to welcome guests to the Institute when conferences and workshops begin. It's also nice to see a strong on-site presence. So far, we've been running either in virtual or kind of hybrid mode, but today I'm really happy to see so many people are here in person. So welcome all of you. Since we have a worldwide audience, I might say a few words about the Institute. Many of you are familiar with the Institute, but for those who are not, we are a think tank for mathematical sciences, and we span the entire spectrum of mathematical research, from fundamental research to applied research, and even to industry-facing and commercialization of mathematical research. We're funded by the Government of Canada through the three major councils: the Natural Sciences and Engineering Research Council of Canada, the Canadian Institute for Health Research, and the Social Sciences and Humanities Research Council. We're also funded by the province of Ontario through the Ministry of Colleges and Universities, and by two American foundations, the National Science Foundation and the Simons Foundation. And in addition, the Fields Institute has a network of about 20 principal sponsoring and affiliated universities, all of which support the work and activities of the Institute. As I said, we are a think tank for the entire spectrum of mathematical sciences research. When the pandemic was threatening to arrive, before it arrived, the Institute jumped into action together with the cooperation of its sister institutes across the country to get mathematicians organized and involved in the modeling and other activities related to the public health crisis. One outcome of that work was a national network called the Mathematics for Public Health. It's one of 5 networks that's funded by the Public Health Agency of Canada. And the goal of this network is to develop models that not only address the needs of today, but go beyond that also and think about future trajectories of infectious diseases and how the country can be better prepared, at least in terms of the modeling activity. So Math for Public Health is now a network of more than 60 researchers across the country, and we're in the 2nd year of operation. And this event is a particularly celebratory event, given the amount of contributions that have been made by the network during the time of its existence. And so we're very pleased that we have an excellent roster of speakers to address issues of topical interest. We're also pleased that both the organization and participation in this conference can be attributed to what's called the next generation, or the younger population of modelers. One of the aims of MfPH was to help train and facilitate the active involvement of younger researchers, and I think the turnout here shows that we've been quite successful in that. So once again, welcome to this festival, MfPHest, and I wish you lots of good discussion and productive discussion. And now I'm going to hand it over to Professor John Hong Wu of York University to introduce our first speaker. Thank you.
Thank you, Kumar. Good day to everyone. And it's my great privilege to present the plenary speaker, Professor Neil Fergusson. Professor Fergusson is not strange to the Fields Institute and its community. During the summer of 2020, in the thematic program on the mathematics of drug resistance in infectious diseases organized at Fields Institute, Professor Neil Fergusson delivered the Coxter lecture series titled Biomathematical Modeling of Emerging Infectious Disease Epidemics and Their Control. Professor Neil Fergusson is also not a stranger to this community. So as Professor Kumamoto mentioned that this event is organized by our next generation mathematical public health next generation, and Neil, your name came from that next generation. Professor Neil Fergusson is a professor of mathematical biology with a long list of pioneer research studies in the patterns of spread of infectious disease in humans and animals. He is a director of Jair Institute for Disease and Emergency Analytics, the director of the MRC Center for Global Infectious Disease Analysis, and head of the Department of Infectious Disease Epidemiology in the School of Public Health, and vice dean for the academic development in the Faculty of Medicine or at the Imperial College in London. During the COVID-19 pandemic, Professor Neil Fergusson has been leading the Imperial College COVID-19 response team. So with this introduction, I'm very pleased to welcome Neil Fergusson to come to the Field University again. Thank you.
Thank you for that kind introduction. And I think you're flattering me to call me the next generation, but I feel that title is being rapidly taken over by younger folks. But let me share my slides. So I thought I would give just a very broad overview of some of the modeling we've been doing from Imperial, but also trying to give a broader perspective on the pandemic. And this is the work of very many people. We had a peak of something over 70 people in the center I had working on COVID-19. I don't have time to acknowledge them all, but I'll show some references as I go along. I'll touch a little bit on what we do, epidemiological modeling, and its different applications in the pandemic. I'll talk about early work we did really up until about mid-March 2020, which was influential in informing control policies adopted worldwide. And then I'll move on to talking about the sort of analytical pipelines we did then. We carried on doing analyses, both global and I'll particularly focus on the work we did in the UK, every week, basically giving a picture on what was happening in the pandemic. And of course, the pandemic changed in 2021 with the occurrence of both new variants, starting with Alpha, and then, of course, the availability of vaccines. And I'll talk about work we did on modeling the trade-off between public health measures and the rollout of vaccination, and finish with a few lessons learned. So this is my friend and colleague, Stephen Riley, who until recently was in the group at Imperial College, is now the head of modeling and data analytics at our UK Health Security Agency, illustrating an equation for a force of infection. In terms of the goals of modeling during this pandemic, I mean, you can split it in any number of ways, but I think a helpful way is to ask, are you looking backwards in time, retrospective modeling, which really is trying to understand past trends and what's happened, estimate key parameters of the pathogen of interest, particularly things like transmissibility, severity, and then later, of course, the characteristics of new variants, or maybe to assess the impact of interventions from observational data, either non-pharmaceutical interventions, NPIs, or vaccines. And in the pandemic, this is because it's more inferential, it's generally been less controversial, though some on the right have criticized work on estimating severity and intervention impact. And then there's prospective modeling, which is really only been a small subset of what we've done. It's generating short-term projections, which we did for almost every week of the pandemic from March 2020 onwards, and using those to inform, let's say, more general policy-oriented risk assessment. And then perhaps the more controversial area is the use of dynamical models to do scenario modeling, investigate potentially counterfactual scenarios of intervention options. So if the pandemic progresses like this, what would be the effect of this sort of measure? And it's, of course, controversial because it affects everybody's lives, what happens, and then it's easy to criticize because, as I'll talk about later, it's very difficult to predict a priori precisely what's going to happen in terms of people's behavior, or the impact of interventions, most of which were novel in this pandemic. Nevertheless, it's been invaluable for policymakers around the world to see that sort of modelling, to get a sense of the trade-offs involved. And we published quite a lot of papers now, and before that, lots of reports and preprints on both sides of this divide, slightly artificial divide, together with some work which kind of spanned the middle. You can think of epidemiological modelling, and apologies for those who are already epidemiological modelers, as a form of knowledge synthesis. I mean, like most forms of social science or health science modelling, we can pull in data on natural history, evolution, impacts of interventions, and then characteristics of the host population in terms of their contact patterns and demography into the model in order to get these outputs we're interested in. Often in peacetime, in less applied policy sense, what we're actually interested in is basic insights into the kind of transmission dynamics of a pathogen and estimates of those kind of fundamental parameters. The more policy-oriented end, of course, is then looking at forecasts and intervention options. Keeping with that slightly artificial dichotomy of prospective versus retrospective analyses, and then thinking about another axis of how early in an epidemic or pandemic you are, then of course there's a high degree of uncertainty associated with modelling, and that's greatest if you're starting early on, doing this beginning of a pandemic and trying to make predictions about the future. Because there's little data or time to do very sophisticated work at that point, and you end up having to extrapolate from other diseases. Most notably for SARS-CoV, we extrapolated from both the original SARS and from influenza. And if you're then looking back on the pandemic, as we are now, with enormous mountains of data, then we have much less uncertainty. The UK put in place an almost gold-plated surveillance system, which I'll come to later, which has provided us with literally terabytes of data. Also, by this point in the pandemic, we have much more established analytical pipelines and tools. We have used a wide variety of model types during the pandemic, quite a lot of basic statistical analysis, albeit informed by a kind of mechanistic understanding of disease transmission and biology. So those might be just simple regression models, survival analysis, that type of thing. And I'll make a reference to that later. It has been invaluable for characterizing things like, for instance, the relative severity of different variants. And then going one step up, where we're actually modeling the dynamics, can start relatively simple with effectively a time series analysis, but modeling the latent process, namely infection. And we produced a number of tools which do that. And I like the work of Sam Batt and Axel Gandhi here, who produced this package Epidemia. And then we do fully dynamical models, i.e. with the feedback process, the epidemic process. And 90% of what we've done in the pandemic has been using more or less elaborate compartmental models just for computation performance. Though we have done both early on and now later, looking at vaccine and immune profiles, we have used microsimulations as well, or agent-based models. And so throughout the pandemic, there's never been one single Imperial model, though nearly all of these models share some basic assumptions, and they're all open source, and I just show them there. And on the left-hand side, the more inferential and analytical, simple models. The right-hand side, the more complex, individual-based models. This has been rather underpinned by the fact that we actually have quite a large professional research software engineering team in the centre, which we started to invest in really from about 2014 onwards, with Rich Fitzjohn, who in the centre of that, who was our first recruit and now heads the unit. And that's there were a number of priorities and associated with certain big projects. We had the Vaccine Impact Modelling Consortium, for instance, initially, but there's been a focus throughout on improving our ability to generate reproducible science through a set of modelling libraries and tools for snapshotting, basically, certain types of analysis in a dependence-free way. It's also, this team have provided a lot of training internally for the researchers and academics who actually still do most of the coding, given we're over 200 of us in the centre, in terms of use of unit testing, of modularity, of API-based programming and just even simple things like GitHub. So with that simple introduction, I'll just step you back to January 2020 and when we first got involved in this pandemic. And there are some early questions we asked at the beginning of every pandemic, and this is a slide I showed in that lecture, I think a decade ago now, lecture series I gave at the Fields Institute. So, you know, what is the true scale of the epidemic when we discover it? Because we know from past experience that cases are always quite often dramatically under-ascertained at the beginning of an epidemic. How fast is it spreading? How much of a threat does it pose? And what can we do about it? But early on, if we go back to 16, well, we started work on this on 10th of January. I think there were 26 cases reported then, really associated apparently with a food market in the city. And it was thought then that it was quite likely these had some sort of zoonotic origin. There was no evidence at that point of human-to-human transmission. But then I heard just reported that there had been a case discovered initially in Thailand, which immediately alerted me and my colleagues to the idea that this could be a much larger outbreak than was anticipated. And that's just because you can do quite a simple calculation to ask, what's the chance in a 1 week period, for instance, that somebody living in Wuhan would turn up in Thailand or fly internationally. So, and that works out to be about a 1 in 600 chance. And so by 16th of January, there had been 3 international cases, 2 in Thailand and 1 in Japan, with only 41 cases reported in Wuhan. But if you multiply 3 by 600, you get something like 1,800. And whilst the actual calculation was a little more elaborate than that, this was our first analysis we published on 17th of January, which came up with estimates that the actual size of the Wuhan outbreak in terms of symptomatic cases, we knew nothing about asymptomatic, was likely to be of the order of 1,700 with a fair degree of uncertainty around that. And as numbers built up in terms of international cases, as well as local cases, but in internationally reported cases, that number grew and grew to, by 3rd of February, to something like 110,000, compared with 6,400 reported cases. And it wasn't as that the Chinese authorities were hiding anything. It was just exactly the situation that most countries found themselves in at the beginning of the pandemic, namely, they had very limited test capacity and they were prioritizing severely ill individuals in hospitals with pneumonia. And the community cases, which were mild or even asymptomatic, were not being detected. Of course, as soon as you get numbers of or even of the order of 1,000 or more, it becomes increasingly implausible that that's down to just zoonotic exposure. It's much more likely that human-to-human transmission is driving the epidemic. And so we came up with some early estimates. One very simple one based on our estimates of the scale of the epidemic, and then estimates from genetic data of the likely origin point of the epidemic, estimates of the order of the reproduction number of about 2.6, with a lot of uncertainty around that, and making rather simple assumption that the generation interval was similar to the original SARS. Later, we got more detailed data from China, the World Health Organization. This is by date of onset of the Wuhan outbreak, date of clinical onset this is. It drops at the end, not because of the lockdown imposed, just because of the data is cut off and there are reporting delays. But you can, again, use simple tools. I think we used MfPHest to estimate the reproduction number. And again, it's highly stochastic, but you're getting estimates in the order of about 2 to 4. Next was the next most important thing, and by far the most difficult thing we did early on, was come up with estimates of the infection fatality ratio. Difficult because, and this is showing the surveillance pyramid associated with any infectious disease, that we knew that surveillance was highly biased to detecting severe cases, with most mild cases, even if symptomatic, not being detected, and obviously asymptomatic infections not being detected at all. And so we had the challenge of trying to work out what the overall area of the pyramid was, with only really having reliable data on the top. There were also some technical issues, statistical issues associated with estimating these things in an exponentially growing epidemic when it takes people several weeks to die after they get reported as a case. And the early infection prevalence estimates we derived from repatriation flights from Wuhan. This is people, non-Chinese citizens who flew out of the city early in the pandemic and landed in countries around the world, and then were all put in quarantine and all tested, PCR tested. That gave us a sort of snapshot of infection prevalence in what we assume to be, of course it isn't random, but assumed to be a random subset of the Wuhan population. And from that, we were able to estimate that the infection fatality ratio at that early time point in China was of the order of about 0.7%. And that in the context of a older UK population would be about 0.9%, with about twofold uncertainty each way in that estimate. But importantly, it was recognized by Chinese clinicians very early on that the risk of death grew dramatically with age, and indeed exponentially with age. And so our later estimates, and they're very similar to other work published by other groups, show this kind of basically a linear line on a log-lin plot with age in terms of the risk of death. And that those figures are from a much later analysis of the first wave of the pandemic with the infection estimates derived from serology data. Given that sort of relatively high infection fatality ratio, of course, there's the risk of overwhelming healthcare demand, but then there's also the question of what can we do about an epidemic like this. And of course, China had locked down 23rd of January, or at least locked down Wuhan and the neighboring and surrounding province. But we had limited data coming out of there in terms of detailed data with which to kind of assess the effectiveness of those sort of measures. But we do have some prior experience. And so we can extrapolate from influenza. And this is work I did of Martin Bootsma all the way back in 2007, looking at the 1918 Spanish flu pandemic in different US cities. And the data is the blue points here. And you'll see some cities have these double bounces. And that's because they introduced, and shown in kind of green lines, introduced non-pharmaceutical interventions, in some cases mini lockdowns, to prevent catastrophic mortality. Then the green lines curves represent the counterfactual we estimated if they hadn't introduced those measures. And so from that analysis, where we fit models to those data to estimate the effectiveness of different interventions, we estimated that, certainly the type of measures, which were school closure, banning mass gatherings, closing churches and the like, might be capable of halving transmission of a respiratory pathogen, such as influenza. There were some other lessons learned from that experience in 1918 as well, that many cities, particularly on the East Coast, started their interventions too late. And interventions were always lifted too early. And of course, there was no vaccine available. They lifted interventions when case numbers came down, and then case numbers bounced up again. And so taking effectively estimates from that, ourselves and a number of other groups, I'd highlight particularly Nick Davis and John Edmonds from London School of Hygiene and Tropical Medicine, looked at different policy options for controlling COVID-19. And really it came down to a strategic question of, do we follow China and suppress transmission and put measures in place which can drive the reproduction number below 1? The downside of that is, as we learned from 1918, if you lift those measures, transmission will bounce up. There's no immunity in the population if you do it early enough. Or do we flatten the curve? Do we mitigate only? Which is what most of the world has done in every previous pandemic. Maybe try to protect the elderly, keep that population group isolated, maybe do some measures to reduce peak healthcare demand, but don't actually attempt to stop transmission. And the decision most countries took was driven by the predictions of the fact that, and observations on the ground in the case of places like Northern Italy, that even if you try to just mitigate, flatten the curve, still the predictions of the scale of the epidemic you would expect would massively exceed any healthcare system's capacity to cope with it. And unfortunately, later in the pandemic, we saw exactly what happened in places like Mexico, for instance, some areas of Brazil, and of course in in India during the Delta wave. Also that time, we didn't just look at the UK and Europe, we also did some global projections using quite simple age-structured SEIR model with those sort of parameter estimates to look at potentially what was the likely burden of disease coming in, which might emerge from the pandemic, but also look at the potential impact of different intervention strategies in every country. And that just based on the age-dependent infection fatality ratio I talked about earlier, we were coming up with estimates of the order of 40 million deaths over 2 years, assuming no vaccine or also assuming no change in the virus. And we thought that might be halved by 20 million if aggressive mitigation strategies, but not actually suppression, were introduced. Suppression strategies or lockdowns could reduce that still further, but would need to be sustained and would require vaccination as the eventual exit strategy. One important insight from that analysis is that we predicted that the lowest income countries would have the lowest per capita burden of disease because they have the youngest populations, and that's what's being shown on the right-hand side there. If you do adopt suppression policies, and I call it suppression because, it's not clear that full mandatory lockdowns are required to achieve suppression. People often mention Sweden, for instance, which achieved very similar overall reductions in population contact rates, but with largely, not entirely, largely non-mandatory measures. But if you're going to adopt a suppression policy, then the aim is to introduce that as quickly as possible, because that will dramatically reduce the size of your first wave. Just simple exponential growth means that if you assume a 4-day doubling time, every 4-day delay leads to twice as many cases and twice as many deaths in your first wave. 8-day delay to 4 times as many. And we've formalized that. Of course, reality is more complicated in doing some counterfactual modeling shown in the right-hand side for the UK first wave of the pandemic, where it turns out to be a week's delay is equivalent to about a 3-fold variation each way in the number of deaths. And from that, but even that very early work, we always predicted that there would be a need to repeat lockdowns. Going back to that 1918 experience of US cities, they work whilst they're in place, but then once you lift those measures and population behavior goes back to something close to normal, you'll have an increase in transmission again. We, of course, modeled algorithmically driven rational policies. And at the time when we were doing this in late February 2020, we didn't assume mass testing of the whole population. We assumed people in hospitals would be tested. So it was being driven, the algorithms we looked at were driven by healthcare demand, basically. And of course, depending on the triggers you use, you can get different outcomes. I won't go into the details of the table on the right-hand side. The important point is that we were anticipating even over if we did it entirely rationally, even over a 2-year period, you would have to pulse these interventions. Of course, what actually happened in Europe was this is over the first year of the pandemic, we saw exponential, this is mortality per million per week. We saw exponential growth, obviously, early in the pandemic, the effect of the first lockdown across and suppression policies across Europe, driving down transmission. Then measures were, of course, relaxed, in some cases almost entirely lifted, and we saw a gradual resurgence of transmission, despite the fact that many countries had tried to put in place test and trace systems. So the slope on the second wave was not as steep as on the first wave, but nevertheless, healthcare demand, mortality increased over time. But of course, governments across the world, with a few notable exceptions, like Denmark, for instance, Norway, a few other countries did act much earlier, but generally countries across Europe were slow to act in the face of the second wave, despite the fact that in some sense the science was fairly clear in my view. And that's because in the first wave lockdown, people were very worried about COVID, but had no experience of what lockdowns were like or the economic impacts and social impacts of those measures. By the second wave, people were very aware of what those measures entailed. And then there was a lot of noise in the popular discourse, a lot of skepticism, all the way down from kind of lockdown skeptics to more conspiracy theory oriented people in society. There was also some hope that the billions invested in test and trace systems might suffice to slow transmission. And so what happened is governments across Europe, at least, tended to adopt these incremental and localized approaches, resisting national lockdowns, instead targeting hotspots gradually. And what that tended to lead to was a kind of leveling up of infection levels. So the regions which didn't have interventions introduced in the hotspots started to get higher and higher infection levels until it was similar across the whole country. And that, unfortunately, the result of that, unfortunately, means that if you look at the UK mortality over the first 2 years, 3/4 of it happened after 1st of September 2020. Now, in part, that was also exacerbated by something I'll come on to next, namely the new variant of Alpha. Before I do, I'll just talk a little bit about our routine analyses. Every week from the UK, and we've been tracking worldwide data, but obviously we get a lot more data from the UK. The UK really put in place a gold-plated surveillance system, as well as mass testing. We also have real-time data on hospitalizations and bed occupancy, down to the individual hospital level, real-time data on mortality, weekly serological surveys, weekly infection prevalence surveys, random testing of the population, more sequencing than, at least for the first year of the pandemic, the UK was doing 70% of all global sequencing of the virus. And then later real-time data on vaccinations. And so, as well as being a huge data processing and linkage exercise, it was essential to have a kind of robust analytical pipeline which could be almost automated to process this information. In terms of the things we came out with week after week, not just in the UK, but in other countries, estimates of R, everybody was obsessed by R estimates, some medium-term projections in a 2 to 4 week timescale, and then more importantly, evaluating particular policy options, mostly on request of government. So this is, as I said, we had the suite of models. This is the more elaborate model used to fit to all that UK data. It's written in a domain-specific language for dynamical modeling, which you can call from R, but actually compiles down to C. And it was quite an elaborate compartmental model in terms of how it represented healthcare demand, because we did want to capture healthcare demand in some detail, both in general hospital beds and intensive care units as well. Stochastic models are fitted with particle filter methods, PMCMC algorithms, highly parallelized way, and the data and the packages used for this are publicly available. So this is a kind of example of the sort of modeling we were doing in the latter half of 2020, looking at the need potential, which the government was resisting, but the need for a second lockdown in November of 2020. The potential impact of that lockdown is represented by the different colored curves. We didn't know what it would be because schools were going to be left open for this second lockdown. But you'll see in all of those curves on the left-hand side, still getting up to levels of daily deaths comparable with the first wave by spring of 2021. So we also then looked at the need for a third lockdown in the UK. And of course, the UK ended up having 3 lockdowns. The situation ended up being worse than we modeled here, because we were doing this in October, modeling in October 2020. And of course, by early December 2020, we realized there was a more transmissible variant circulating in the UK. In parallel, we've done, again, with similar but slightly simpler models, parallel work for low and middle income countries, producing estimates for every country in the world of the reproduction number and scale of the epidemic, similar modeling framework, dashboard where countries could look at those estimates, but also online, no longer up, but online modeling tool for countries to look at the impact of interventions, including vaccination and quite a lot of bilateral work for governments. One of the challenges in modeling the rest of the world is we knew testing was very limited. And so we mostly based estimates on mortality data on the basis that a higher proportion of deaths would be tested, severe cases would be tested, but then started later feeding in the excess death data becoming available from a variety of estimates. Other work we were doing, this is going back to the more kind of inferential modeling, kind of simpler semi-mechanistic modeling, was looking back on the pandemic and trying to estimate the impact of interventions. And this can also is also a package which can be used to do projections. And so the first work on this was Seth Flaxman's Nature paper in 2020. There, that actually treated lockdown as a single intervention type, and in later, more nuanced work, Browner et al. In Science later in 2020, because no two countries defined lockdown in the same way, or stay-at-home orders in the same way, we broke up that single intervention into its component pieces. And they did a much more elaborate job of categorizing exactly what interventions were put in place in 40 countries across the world. And then the net conclusion of this, which might seem obvious, is the net effect of lockdowns was down to the cumulative sum of the individual reductions of contact rates in different contexts. This package also allows you to then, fit to an ongoing epidemic and generate estimates of reproduction number on the right-hand side, reproduction number estimates on the right-hand side. And so this was used throughout the pandemic at local authority level in the UK to generate, again, a dashboard of short-term projections for every local authority area and reproduction number estimates, things which look like that. This is Bolton and north of England, for instance. 2021 was, of course, the year of variants and vaccines, two things which fundamentally changed how we modeled the pandemic. Prediction is always hard of any sort of epidemic because, particularly if it's an previously unknown pathogen, we can't necessarily reliably estimate the effect of interventions in advance, particularly non-pharmaceutical interventions. And could be a separate lecture, there was lots of spontaneous behavior change as well at different points in this pandemic. But it's at least easier to model the spread of a virus where there's no significant immunity in the host population. But with the advent of vaccination and naturally acquired immunity, as infection levels went up again in the second wave, things got more complicated, and variants added to that with different epidemiological characteristics, being more transmissible and initially more severe, and then in terms of Omicron, less severe. I don't have time in this lecture to go into the details, but we've been at the forefront of characterizing new variants. Eric Volz characterized this D614G mutation, which is actually the form of coronavirus which dominated the first wave in Europe and North America, but is different from the Wuhan strain. And then the B117 or alpha lineage, which was really almost co-discovered by Eric Volz and Andrew Rambo. But we've worked also with colleagues in Brazil on the gamma variant, P1, did a lot of work on Delta and did a lot of work on estimating the severity and transmissibility of Omicron as well. Also this really work started in October 2020 and really led by Alexandra Hogan and Azra Ghani. We're doing a lot of work for Gavi and the World Health Organization and CEPI, looking at how when vaccine became available, how might it best be used? What's the optimal age targeting, trading off potentially reducing transmission more by vaccinating younger people versus directly protecting people most at risk of disease, the elderly. And most of that analysis suggested, at least in the short term, it would be optimal to vaccinate those people most at risk to start with. In terms of sort of modelling we were doing for the UK government in 2021, we entered 2021 in a third stringent lockdown with schools closed, everybody working from home. But of course, vaccination was being rolled out at that time point, and the government wanted to be able to relax the lockdown as quickly as it possibly could, but under a constraint that it did not want another wave of transmission, which would, threaten to overwhelm the health system. And so there was a direct trade-off between increasing immunity in the population and increasing contact rates caused by relaxing control measures. And so we did a lot of modeling, these are some scenarios looking at the potential timing of relaxing lockdowns. The net conclusion was first of all, we couldn't precisely predict what would happen, and so it was important to be incremental, reducing, in a staggered reduction of control measures, but also then assess each measure in turn. But we came to an overall conclusion that it would be at least the summer, really, before we could lift all measures, given the projections of how quickly we could roll out vaccine and the vaccine effectiveness estimates. And that did turn out to be the case. Of course, we got multiple additional variants in 2020, particularly the Delta variant, even more transmissible. I should say both the Delta and Alpha variants were more severe, higher risk of death than the wild type variant, slightly countered by the fact that we had ever increasing better treatment for COVID as the pandemic progressed. But the Omicron era was fundamentally different. I mean, it proceeded around the world from Southern Africa, but showed in the UK the most rapid growth of any variant we'd seen. And it was clear that was due to immune escape. We're getting high levels of reinfection of people who had previously had COVID. And because UK had this, gold-plated surveillance system with data linkage across all those data streams, we were in a good position to come up with some of the first estimates of the relative severity of Omicron compared with Delta. How much less likely was it to kill you if you were infected? Massive data linkage exercise, and basically two analyses came out. One smaller South African analysis on the 21st of December, and our own analysis on the 22nd of December, which estimated that really there was probably about a 60% lower risk of hospitalization for Omicron compared with Delta, and a 70% reduction in risk of death. And then we elaborated that analysis in collaboration with UKHSA and the Cambridge Biostatistics Unit to actually estimate how that reduction in severity varied by age, which are these graphs you can see on the right-hand side here with different endpoints. One of the interesting things about that analysis is that the actually intrinsic reduction in severity was even larger. If you'd never been exposed to COVID, never been vaccinated, then probably the risk of death had dropped by as much as 80%. If you were in your, anywhere between 30 and 70 years of age. But that was slightly countermanded by the fact that it was an immune escape variant, so vaccines and prior immunity was slightly less effective. It's the difference between the blue and the orange points on those graphs. And since then, what we've been seeing is really driven by Omicron and ever diversifying, and we really have no evidence that any other lineage is now circulating. Delta and Alpha outside labs seems to be extinct. Now, we should need to keep an eye on those labs going forward that we don't accidentally release it again. But what we've seen with the Omicron is gradual diversification. BA1 was the first Omicron strain, and we rapidly then had BA2 causing a second wave of transmission in the UK and across Europe, across the world thereafter. And since then, it's been diversifying even more, BA4 and 5 and multiple other variants. And so we've seen, and you see in a second, I'll show you now, you see the 2022 onwards, we've had 4 waves of infection in the UK this year, all driven by Omicron. All of them much lower, even than hospitalizations than we saw in the first 2 waves, much, much lower in terms of deaths. Partly because of the effect of vaccines, partly because of this reduction in severity. I should say not all hospitalizations are the same as well. I mean, those people being hospitalized now are generally less ill than they were in the first 2 waves. But still, significant healthcare burden, even though it is being mitigated by additional booster doses, including bivalent boosters with Omicron in them. But this circulation is happening in the context of very high population immunity in most of the world. It's quite remarkable that infection prevalence in the UK has been above 1% all year round so far from our infection prevalence surveys. And of course, that very high infection rate is driving the net rate of mutation of the virus, allowing it to explore many, many different antigenic trajectories and antigenic space. Not clear whether this can be sustained. And of course, if the global infection incidence starts to drop, then so will the mutation rate, and that will start becoming, to some extent, a vicious cycle. And we might then reset to a much lower level of infection than we have seen this year, at least. But there are many uncertainties attempting to model this. We've only done some very simple models thus far. We don't know, what the limits are to the virus being able to explore antigenic space and escape immunity. We don't know how hosts will respond to repeated exposure to both vaccines and the virus, and how immunity will accumulate. So I'll just finish off in the last few minutes with a few lessons. Just going back to global mortality. So far, this is out of date actually, 6.5 million reported COVID-19 deaths to date. But we know from analysis of excess death data and modeling of excess death data that probably true mortality is about threefold higher than that. There are multiple estimates by different groups. IHME and The Economist came up with really quite comparable estimates of about 18 million to the end of 2021. WHO, slightly lower estimate, didn't use quite so, decided to go for simpler methods in the aim of transparency. But all of these are in the same ballpark as our 20 million over the first 2 years of the pandemic estimate we made in March 2020. But of course, reality differed from our model. We didn't anticipate new variants, which have made a big difference to the burden of disease, SARS-CoV-2 has more than doubled its transmissibility due to mutation. But neither were we modeling the effect of such rapid vaccine rollout. And in reality, whilst that 20 million estimate was for a mitigation scenario, there were a whole mix of policy options used at different times in different countries. We've also done nice analysis by Oliver Watson, used to be with us, published in Lancet ID, an analysis of the global impact of vaccines, the deaths averted globally. Now, in making any such estimate, you have to pick a counterfactual. And so the counterfactual we picked was that all other policy options would have been the same if vaccines hadn't been available, which is arguably oversimplified, but it's hard to, at least is a clear counterfactual. Under that counterfactual, we estimate that some 20 million lives were saved by vaccination, obviously in 2021, mostly in high-income countries for two reasons. First of all, high-income countries have older populations, higher burden of disease, but they also had access to vaccines. As we know, there's been a lot of global inequity in vaccine access, and coverage is therefore much lower in low-income countries. It's also, I think, relevant to look back on how different countries did in the pandemic and learn lessons. And whilst nearly every certainly high-income country I know of has got some official inquiry underway, if it hasn't already finished, on how did the government and the science community do in helping protect their populations, I think it's quite important for countries to look beyond their borders at what similar countries did. Canada is not on this. Oh no, it is on this list actually. It's up at the top. So you see the UK here, 2,344 COVID deaths per million of the population. We're better than many other countries, including the US, but worse than many countries, Canada included, did considerably better, half the number of deaths. And countries like Norway, Finland, and Denmark, better still. And understanding, there are some clear indications of what caused those differences. Vaccine uptake is one, which explains the incredibly high death rates right at the bottom of this slide. But also the timing and rigor with which interventions were put in place until high vaccine coverage was achieved in populations is the other one. Plus a set of intrinsic differences between countries in health system quality, comorbidities, many other things. And so it does, it's a topic of not just, idle speculation and commentary. I think it is an important topic, this sort of comparative analysis for future research. And my last slide, just a few general reflections to finish. I think one thing we saw, and it's going to be a challenge to do better next time, but we've got to think of ways of doing it, is that I think for nearly every country of the world, initial testing was inadequate in terms of capacity and misdirected. A lot of countries spent a lot of time trying to test travelers coming into their airports without putting in place rapidly enough, at least sentinel surveillance in their own populations. As the last slide referred to, small differences in the timing of non-pharmaceutical interventions in the early waves and later waves of the pandemic led to big differences in net mortality. Part of that is down to something which I could give another lecture on, down to the political polarization which emerged in the COVID pandemic. Worse in countries like, for instance, Brazil or the United States than in the UK or Canada, but we had plenty of it as well. So whilst the second wave was predicted by all the models, perhaps it was unavoidable that governments would be slow in responding. The occurrence of variants really justified the enormous investment the UK put in very early in the pandemic to tracking, to real-time genetic sequencing of the virus. I mean, that is something I think the UK can be truly proud of. It was doing bulk of the world's sequencing for the entire first year of the pandemic. More generally, I mean, I think whilst there's been an unrivaled scientific coordination across the world between scientific groups during the pandemic, the political coordination has left something to be desired. I think the UK actually did punch above its weight in research on the pandemic, epidemiological and clinical, partly a strategic investment pushed by our chief scientist and chief medical officer, Patrick Vallance and Chris Whitty, to persuade the government that it was worth investing a small percentage of what was being spent on furlough and everything else on research, and that reaped rewards, but also a benefit of having a national health system with integrated electronic patient records such that we could do the data linkage in real time. It wasn't easy, but we managed to achieve it in ways which other health systems would not be able to achieve. I think I would say this, wouldn't I? I think analysis and modeling, mathematical modeling has played an important role, but only one role in terms of informing policy making. And something which I could give another lecture on, and we're spending more time looking at epidemiologically, the people who paid for this pandemic were the poor in society, the poorest countries in the world, and the young basically sacrificed future prosperity to some degree to protect the old. And that's something the world needs to be cognizant of and do something about. Thank you.
Thank you, Professor Fergusson. So thank you very much for your grand review of the past 3 years experience, and looking forward to the future paths.